We want to thank everyone for tuning in to this series on the intersection of MASH and cardiometabolic risk. And we're going to do this by going through some patient cases and a discussion about the treatments around this disease state. I am Amreen Danani, one of the hepatologists at Duke University School of Medicine. I'm an associate professor of medicine in the Division of Gastroenterology and Hepatology. And today I'm joined on this series with Dr. Jennifer Green, who's a professor of medicine in the Division of Endocrinology, who's also at Duke University School of Medicine. Welcome, Dr. Green. So we're going to dive right into treatment. If you are interested in learning about diagnosis, risk stratification, please tune in to our previous podcast that will give you some information about who should be screened and what tools can you use to risk stratify the patient population. We're going to start this out with a case. And so this is supposed to highlight a patient that we see in primary care and a common scenario to a lot of us in the primary care setting in endocrinology. So here we have a patient with type 2 diabetes and a new diagnosis of MASH. So just for everyone's knowledge, MASH is metabolic dysfunction associated steatohepatitis. So this is by definition a person who has hepatic steatosis and also has the inflammatory features called steatohepatitis based on histology. So this is a 60-year-old female with obesity. She has a BMI of 36, who also has hypertension, hyperlipidemia, and has a 15-year history of type 2 diabetes, who has abnormal aminotransferases going for many years. She does not drink alcohol. She's been trying to limit intake of calories and particularly carbohydrates, but has been unsuccessful in losing weight. Her current medications appropriately are amlodipine, enalapril, metformin, and omeprazole. Her atorvastatin was held due to the elevated aminotransferases, which we also see very commonly happen in the primary care setting. So before we truly go into the treatment of MASH, I would just like to highlight that to take care of these patients really does require a concerted effort of multiple subspecialties. And so here, what we're trying to illustrate is that the patient really is central to care management, but primary care and endocrinology really play a big role in taking care of these patients. Primary care can start off by doing some initial testing, such as a FIB4, and do some further risk stratification before they refer these patients on to subspecialty care, such as hepatology or gastroenterology, for further workup and guidance on treatment. So back to our case. So again, she's a 60-year-old female with obesity, hypertension, hyperlipidemia, and a 15-year history of type 2 diabetes who has elevated liver enzymes for many years. Here, what we have are additional workup that was already performed on this patient. So you can see here, she has an albumin of 4, an alkaline phosphatase of 112. Her aminotransferases, which is an ALT and AST, are high. So an ALT of 92, an AST of 80. By definition, an ALT or an AST of greater than 30 is considered abnormal. Her bilirubin is normal at 0.6. Her platelets are normal at 210. Her diabetes, a measure of control of her diabetes is defined with a hemoglobin A1C of 7.6%. She has hypertriglyceridemia. Her triglycerides are elevated at 210, and she has an LDL of 120. This physician went ahead and did some non-invasive testing, and here you can see that the patient has a FIB4 of 2.4, which puts her in the category of indeterminate fibrosis, and a vibration control transient elastography of 16 kilopascals, which would be considered as having a risk of having advanced fibrosis. This patient went on to have further workup with a liver biopsy and was found to have steatohepatitis with extensive bridging fibrosis, but not cirrhosis. So on a histological staging system, we would define this person as having MASH with F3 fibrosis. And again, has a negative viral serology workup, and other causes of elevated liver enzymes was also worked up, which was negative. So, Dr. Green, before we go into some of the treatments of for MASLD and MASH, can you walk us through the algorithm in terms of other organs that we should be thinking about in addition to liver health?
Absolutely. And I really like this figure because it covers everything sort of from soup to nuts, from, outlining the high risk groups for this condition. And then what we really need to focus on from an evaluation and therapeutic perspective once we have determined that the person has clinically significant steatotic liver disease. So a reminder that people with prediabetes or type 2 diabetes are a high risk group. People with obesity and or 2 or more cardiometabolic risk factors, and people with hepatic steatosis on imaging, and certainly those with an AST or ALT above 30 should be considered at risk for this condition. Now, if we move on a bit, this is a patient who has already been diagnosed with MASH. So we need to focus now perhaps less on diagnosis and now on interventions that can reduce her risk of morbidity and mortality moving forward. And we had mentioned in the other module that people with MAFLD and MASH are at high risk for cardiovascular disease. So that must be really at the front of mind for management of these individuals. And of course, we can focus on that by managing obesity, their glucose levels, their blood pressure, and addressing their atherogenic dyslipidemia. And I think it's incredibly important to remember that statins are safe in this population and are first-line therapy to reduce risk by altering lipid levels. Now, of course, we want to consider interventions that can reduce the risk of these individuals progressing to cirrhosis. And again, we have quite a lot of information about her fibrotic stage. She's F3, as you mentioned. So we're going to talk about interventions to reduce the risk of progressive liver disease as well. We can't forget that any sort of pharmacotherapy that we would consider for the treatment of these individuals is are really interventions that should be superimposed on a foundation of lifestyle modification. And almost everyone with MAFLD or MASH can benefit from interventions to address their excess weight. And it's recommended that a caloric deficit, we know that a caloric reduction of 750 to 1,000 kilocalories per day can improve insulin resistance as well as hepatic steatosis. We specifically recommend that people limit their intake of fructose. From a liver health perspective, if people drink caffeinated coffee, taking in 2 or more cups of caffeinated coffee can be of potential benefit. And of course, we recommend no heavy use of alcohol and, if possible, avoidance. From the weight loss perspective itself, weight loss of 3 to 5% of body weight has been shown to improve steatosis. And more importantly, a loss of body weight in the 7 to 10% range can, in fact, improve NASH fibrosis, which is a very, very important outcome and benefit of that degree of weight loss. Exercise, very important from a weight management perspective. I would say from an endocrinology perspective, particularly effective in helping people keep off weight that they've gained. But there's some evidence that exercise may reduce steatosis. We don't really know what the effects of exercise on NASH or hepatic fibrosis are at this point. But again, there are a variety of other benefits associated with exercise in this particular patient population. And current recommendations are that individuals participate in 150 minutes per week of moderate intensity exercise, or they can take the shortcut of at least 75 minutes per week of more vigorous activity. We can also, in some individuals, consider bariatric surgery for MASH. And I actually think we don't consider the option of bariatric surgery in enough people with diabetes, excess weight, with or without liver disease, to be honest. And often it's an option that is considered when people's comorbidities are very far advanced. So I would like to remind everyone that this can be an option at early stages. This is an intervention that can be very effective for long-term MASH resolution and regression of hepatic fibrosis. There are data suggesting that bariatric surgery in MASH individuals can, at a year, result in 84% NASH or MASH resolution without worsening of fibrosis. And at 5 years, again, studied in a smaller subset of individuals, actually has been shown to also be associated with a 70% regression of fibrosis by at least one stage. Now, as I mentioned earlier, we can't think about this at very late stages because bariatric surgery is not recommended in individuals with decompensated cirrhosis. So this is an intervention that should be considered at much earlier stages. And the mechanisms of benefit are certainly in part through weight loss. There also are increases in serum bile acids, and there can be suppression of lipogenesis via various bile acid pathways. There are a number of pharmacotherapy options for MASLD and MASH that should be considered, and there are many ongoing clinical trials. The guidelines that currently exist recommend that we use currently approved medications to treat associated comorbidities in these patients, and that we use medications with demonstrated efficacy in NASH or MASH. And I'll talk a bit more about use and the benefits of GLP-1 receptor agonist and other incretin-based therapies, as well as pioglitazone on some subsequent slides. Excitingly, though, there is a very recently new FDA-approved option, which is a selective thyroid hormone receptor beta agonist called resmetirom that we'll talk about next. A reminder that the FDA has fairly stringent requirements, and in order to approve a drug for these conditions, and the hepatic histologic endpoints that the FDA considers likely to predict a clinical benefit include evidence of MASH resolution. So that is a resolution of steatohepatitis on histology with no worsening of liver fibrosis, as well as improvement in fibrosis itself by at least one stage and no worsening of steatohepatitis. So I think we should start with the newly approved agent first. So Dr. Dhanani, can you talk us through what we understand and know about the agent that works through the thyroid hormone receptor beta pathway?
Yeah, absolutely. So very recently we have approval of the very first and only medication for patients with MASH with moderate to advance fibrosis. So that correlates to patients who have F2 or F3 fibrosis. And we'll go into some of the details of the medication. So in general, this is a thyroid hormone receptor beta agonist. The medication is called resmetirom, which is the new name. The way this molecule acts is there is a specific impact on the liver by binding to the beta subunit, which is found in the liver. And what it does specifically is controls the lipotoxicity pathways by improving the lipotoxicity. So it decreases intrahepatic triglycerides. And in turn, what it does is it improves free fatty acid oxidation. It has also been shown to improve mitochondrial function and overall improve cholesterol metabolism. And there is data to support that it has both direct anti-inflammatory and anti-fibrotic effects. So this is a target that we find in the liver, very specifically acting on cholesterol metabolism and our lipotoxicity pathways. I'm going to share results of the phase 3 study that led to approval of the first medication for MASH in this space. So the medication is resmetirom. So these are results from the phase 3 study, which included 888 patients who had a histological diagnosis of MASH. And these patients had moderate to advanced fibrosis. So histologically, that is categorized as patients with F2 or F3 fibrosis. There were two primary endpoints for this study. The first primary endpoint, as Dr. Green had mentioned earlier, is NASH resolution with no change in fibrosis. And the secondary primary endpoint is improvement in liver fibrosis by one stage with no change in steatohepatitis. Patients were randomized to 3 arms, a placebo arm, an 80 milligram arm, and a 100 milligram arm. As you can see, there was a significant improvement in steatohepatitis in both the 80 milligram arm and the 100 milligram arm compared to placebo. And similarly, a significant and exciting response seen in fibrosis improvement in both doses of resmetirom compared to placebo. This medication was generally well tolerated. The most common side effects were diarrhea and nausea, which were managed well. The medication has no true contraindications. We just have to watch, make some dose adjustments for statins. But in general, this medication can be prescribed to any patient who has a diagnosis of MASH, who have moderate to advanced fibrosis, which would correlate to stage 2 and stage 3 fibrosis. And the biggest exciting news about this medication is that it does not require a liver biopsy. So again, here to reinforce that we have multiple non-invasive tests, such as FIB4, FibroScan, ELF testing, and others that can really be combined as sequential testing to truly risk stratify our patients so we can appropriately treat them with this first liver-directed medication.
Great. Thank you so much for that. So again, this is the first FDA-approved option for the treatment of patients with MASH. But I would like to take a bit of time to discuss the use of other pharmacotherapy for the management of patients with MASLD and MASH. And to reiterate, these are classes of drugs that are approved for the management of other conditions, such as overweight or obesity, and type 2 diabetes. However, they are interventions that either directly or indirectly are considered to benefit individuals with MASLD and MASH, and should be considered strongly, particularly if they have other indications for use of these medications. Now, the GLP-1 receptor agonists are a relatively recently developed group of drugs, and essentially they mimic the effects of a gut hormone, GLP-1, and the GLP-1 receptors are really widespread throughout the body and are present on a wide variety of organs and cells. And therefore, when you give a person with a GLP-1 receptor agonist, they're considered to have a wide array of physiologic effects, which are particularly helpful in glucose lowering in people with type 2 diabetes and also for weight management. And these drugs help reduce weight both through central mechanisms. Essentially, they make people feel more full and they eat less. They also slow gastric emptying, which also can result in people eating less at meals. But they have a variety of other potentially and important, potentially cardioprotective effects, including not just glucose lowering and improvement in lipid levels, but there may be direct effects on the endothelium and myocardial cells to reduce cardiovascular risk. And of course, in people with diabetes, they lower glucose by increasing insulin secretion and decreasing glucagon secretion. The drugs also, to a certain extent, improve insulin sensitivity in peripheral tissues, but it's probably not the primary way through which they lower glucose. And there are emerging data that suggest that GLP-1 receptor agonists provide particular kidney outcomes benefits as well in patients with type 2 diabetes and chronic kidney disease. Now, many of these physiologic actions can improve hepatic health as well. And we think that through many of the mechanisms that I've just described, that this class of agents may decrease hepatic inflammation, hepatic fat content, and can, in some cases, promote the resolution of MASLD or MASH. And I'll walk through some examples of that. I'd just like to point out that these are drugs that have a particular indication for use in people with type 2 diabetes and high risk of atherosclerotic cardiovascular disease, either because they already have a diagnosis of ASCVD or because they have multiple risk factors for ASCVD. And this is not necessarily demonstrated with every agent in the class, but we do know that several, including semaglutide, dulaglutide, and liraglutide, have all been shown to decrease cardiovascular risk in this particular high-risk patient population. And because we know that there's a great deal of overlap between MASLD and MASH, diabetes and cardiovascular disease, many patients with MASLD or MASH may have separate indications for use of one of these three GLP-1 receptor agonists, specifically to reduce their cardiovascular risk. So they're an excellent intervention for people with these serious and overlapping conditions. Now, again, the GLP-1 receptor agonists are not specifically indicated at this time for the treatment of MAFLD or MASH, but there are interesting emerging data. These are data from a trial of subcutaneous semaglutide in people with NASH or MASH. And what was shown in this group of individuals with fibrosis stage 2 or 3 at baseline, who were randomized to one of 3 doses of semaglutide, which was not dosed in the traditional once weekly way, but at different cumulative doses of semaglutide versus placebo. You can see here that the proportion of patients who had resolution of steatohepatitis without worsening of their liver fibrosis was really quite considerable in the individuals randomized to any of the doses of semaglutide, but being most pronounced or greatest at the higher dose of semaglutide, 0.4 milligrams given several times a week, and certainly greater than the degree of, than the proportion of individuals who experienced that degree of improvement who were randomized to placebo. Of course, these drugs are associated with weight loss, and you can see that patients randomized to one of the three doses of semaglutide, lost either 5, 9, or 13% of their body weight, depending upon the dose that they were assigned to. And this is the degree of weight loss that we expect to see with use of this medication. And essentially what this slide shows is, and it focuses on the proportion of individuals in the three different semaglutide treated groups, as well as the placebo assigned group, who had progression of fibrosis. And the progression of fibrosis, as you can see, was much higher in the placebo assigned individuals, being nearly 19%, and being lower than that, ranging from about 5 to 10% in the semaglutide treated groups. It's important to know that the incretin-based therapies and options for treatment with these incretin-based agents, it's really a very dynamic space, and we now have clinically available what's called a dual incretin agonist, and tirzepatide is commercially available for the treatment of type 2 diabetes and or overweight or obesity. And this is actually a drug that is not just a GLP-1 receptor agonist, but it's also a GIP receptor agonist. And this drug appears to, in people with obesity, result in reductions in body weight that exceed what we see with even the most potent GLP-1 receptor agonist. And this particular agent, tirzepatide, has had a particular trial that included an MRI sub-study assessing changes in liver fat content in people with type 2 diabetes who were assigned to treatment with 3 different doses of tirzepatide, or instead to a basal insulin, insulin degludec. And what you can see on the right-hand side of this slide is the liver fat percentage change from baseline in each of these 4 treatment groups. And you see very considerable reductions in liver fat content in all of the tirzepatide doses that were studied. And again, this reduction in liver fat content significantly greater than what was seen with treatment with basal insulin. And we can't forget, our old friends, the PPAR agonists, for patients with MASLD and MASH. And, the PPAR agonists that we're probably most familiar with are the thiazolidine diones, and with pioglitazone in particular being the agent that is most commonly prescribed at present, and primarily being prescribed for the management of type 2 diabetes. But it is important to remember that the PPAR agonists probably play a very important role in the management of MASLD and MASH as well. And although these drugs are not specifically FDA approved for the management of MASLD or MASH, they really are present and recommended in essentially all of the guidelines for management of patients with MASLD or MASH, and should be considered as a therapeutic option that is often quite inexpensive and effective in the management of steatotic liver disease. Again, pioglitazone in particular is a PPAR gamma activator, and but all of the PPAR agonists work by agonizing nuclear receptors. PPAR gamma activation in particular is known to improve peripheral adipose tissue insulin sensitivity, and improves glucose levels primarily through increasing glucose uptake into the adipose tissue. And they're also associated with reduction in inflammation. There are other PPAR activators that are not as readily available, but do appear to convey other benefits which may be important to the treatment of patients with MASLD or MASH. And they primarily work through altering lipid metabolism in a very favorable way. But PPAR gamma activators are really those that have been clinically available for management of patients with diabetes and MAFLD or MASH. And there are some very well-known and well-described trials demonstrating the benefit of pioglitazone in patients with non-alcoholic steatohepatitis and either pre-diabetes or type 2 diabetes. And the results of one such study published in 2016 are shown here. And if you look towards the right, what you can see is the effect of pioglitazone on hepatic steatosis, inflammation, ballooning, and fibrosis in this patient population. And you can see statistically significant reductions in all of these parameters with pioglitazone treatment. With respect to all of those parameters of liver health. And also in the same study, there was a significant proportion of individuals treated with pioglitazone who had either a 2-point or greater reduction in NAS without worsening of without worsening of fibrosis, as well as 58% of individuals who had complete resolution of NASH. So this is a therapeutic option which has demonstrated significant outcomes benefit in patients with NASH and should be considered for the treatment of such patients. Now, one of the obstacles to the use of pioglitazone, particularly in people with type 2 diabetes, has been that these are drugs that are known to increase weight and also to expand plasma volume, and in some situations can cause adverse side effects related to fluid retention or volume expansion. Now, the good news is that if you give pioglitazone to either a GLP-1 receptor agonist or another class of medication called an SGLT2 inhibitor, the impact of the pioglitazone treatment on both weight and volume status can be attenuated very significantly. So, for example, on the right-hand side of this slide, what we see are the results of a study that shows that when semaglutide, the GLP-1 receptor agonist, is added to pioglitazone therapy, people will still lose weight. It may not be quite as much as they would have lost if they were not on pioglitazone, but we have other tools, again, that can mitigate the potential adverse effects of pioglitazone on, again, both excess weight and volume expansion. So we should be thinking more broadly and thinking about combinations of therapies which can be particularly beneficial and well tolerated in our patients with MAFLD and MASH. So, Dr. Dhanani, there are many, many more therapeutic options which are on the horizon. Would you walk us through what you think are some of the up and coming therapeutic options?
Yeah. First, Dr. Green, thank you so much for reviewing that because, we just got approval for a medication for this disease, but up until now, we have, as you've illustrated, some pretty good treatment options for other metabolic comorbidities that can be impactful to MASH or NASH, and also improve other, metabolic comorbidities. So things that we should be thinking about in this patient population as well. So going back to Dr. Green's question, there are multiple molecules that are being investigated in this space at this time. And here we just highlight a few of these molecules. So retatrutide Tutride. This is a GLP-1 receptor agonist, a GIP receptor agonist, and also and a glucagon receptor agonist. This is a molecule that was tested in patients who had type 2 diabetes and MASLD or MASH, and really exciting results because we were able to show the study was able to illustrate that greater than 90% of MASLD resolution at 48 weeks with both treatment doses of 8 milligrams and 12 milligrams. There are other, we talked about PPAR agents. So lanifibranor is a current molecule that is being investigated. This is a pan-PPAR, so it works on all of the different nuclear receptors. And this is currently underway in a phase 3 study. So more to come over the next year or two. And then we have other agents, which are called FGF21 analogs, that are currently also going to be starting up in phase 3 studies, which in phase 2 studies have shown to be impactful not only in MASH resolution, but also have shown a pretty pronounced impact on fibrosis and improvement. So we do have several agents coming up in the later stages of clinical trials, so phase 3 trials that we should have readouts on over the next several years. So we are hopeful that we will have more medications in this space. So we would like to ask a question after we reviewed some of that information here. Which of the following agents has been shown to result in MASH or NASH resolution and improved cardiovascular risk? The options here are semaglutide, which we reviewed here, empagliflozin, which is a SGLT2 inhibitor, pioglitazone, which we are all familiar with, that we use for type 2 diabetes, and the last option is vitamin D.
Well, I'm happy to help answer this question. I hope everyone was listening. So I think the best answer to this question is the GLP-1 receptor agonist semaglutide, and certainly in people who have MASH and type 2 diabetes who are at high risk or who have atherosclerotic cardiovascular disease, semaglutide is going to be the option that really has been shown to kind of check all those boxes. So semaglutide would be the option that would be, I think, I would recommend as the best answer.
I agree.
However, we can think about combinations of these different agents, particularly, for example, if the patient with type 2 diabetes, as they often do, needs more than one medication to control their blood sugar. You could use various options of A, B, and C, if not all of them, and potentially give multiple medications, which might favorably impact their liver disease.
Great. So, to wrap up, we're going to go back to our original patient. She was a 60-year-old female who had multiple metabolic comorbidities such as obesity, hypertension, hyperlipidemia, and a long-standing history of type 2 diabetes. Just to refresh your memory, these were some of the laboratory values that we had at baseline on this patient. We have a panel of non-invasive tests that suggest that this patient has advanced fibrosis. And then we have a liver biopsy that confirms that she has steatohepatitis with bridging fibrosis. So, as we mentioned, the backbone of treatment is lifestyle intervention, no juices, no soda, really encouraging people to read their labors, moving, any form of movement up to 150 minutes, and really focusing on the medical management of these comorbidities. Dr. Green, do you have anything more to add to the management of this patient?
I would just like to reiterate that these patients should be on statin therapy. She has multiple reasons to be at high risk for cardiovascular events. And it's very clear that statin therapy is safe in these individuals. She needs to get back on her atorvastatin that she was taken off of out of concern that it was contributing to her liver disease. We know that that's not the reason for her abnormal LFTs. As far as contemporary therapies that would be best for her, again, like we talked about in the previous question, I think semaglutide or another GLP-1 receptor agonist, really depending on what she has access to, would be a very nice addition to her current regimen. So she has a hemoglobin A1C of 7.6%, which is a little bit above goal. The semaglutide will lower her A1C further, but the good news is since you're adding it to metformin monotherapy, she will not have hypoglycemia, even on that combination. And we could think about resmetirom once that is commercially available. And again, because that is a medication that works through certainly very different physiologic mechanisms to improve liver health, I don't see why she couldn't be considered for combination therapy. She should be screened regularly for hepatocellular carcinoma. And the importance of vaccinations cannot be overemphasized in this patient population, just due to diabetes alone, I would say. People are often, from a very young age, have indications for a whole host of vaccinations, including, for example, for hepatitis B, that are just, I think, not well appreciated.
Thank you. So Dr. Green, help us wrap it all together. And what are your takeaways from this?
Sure. So I hope I emphasize that although we talk a lot about pharmacotherapy for this patient population, and we rightly so, we cannot think about pharmacotherapy without really understanding that those therapies should be in addition to as much lifestyle modification as can be achieved by the person with MASLD or MASH, and in particular, interventions which result in weight loss. We should be thinking about combinations of pharmacotherapies, particularly in people with MASLD or MASH and type 2 diabetes and excess weight, including those that, although they may not be specifically approved for the treatment of MASLD or MASH, are approved for type 2 diabetes and obesity, that have been shown to reverse steatohepatitis, to slow or halt fibrosis progression, and importantly, to reduce cardiovascular risk in these patient populations. As we've mentioned multiple times, there is a new, and it's the only FDA-approved therapy, resmetirom, which will provide additional therapeutic options for our patients in future. And don't forget that these patients, again, because of their high cardiovascular and kidney risk for that matter, they also require management of their more traditional cardiovascular risk factors. So blood pressure, lipid management, really statin therapy focused, smoking cessation, etc. So I hope that's helpful. I think these are key takeaway points that fortunately have a lot of overlap with a lot of other conditions and comorbidities that we're already currently managing. And I very much enjoyed discussing this case and contemporary management of MASLD and MASH with you.
Yeah, this was great. Thank you so much for joining me.